Okay, hopefully we've had a bit of a break and a chance to digest the first two videos. We're just going to go on to the final one in this week's set, where we're going to be talking about some of the issues associated with some of these more complicated design decisions. And in particular, I'd like to talk about some of the difficulties that arise when you're scanning patients of different groups relative to normals, as well as the considerations that need to go through your mind when you're thinking about whether or not to collect behavior as part of your fMRI experiment. So one of the promises of fMRI back in the day was, man, we were finally going to figure out what was going wrong in some of these like neurological patients or patients that just have sort of functional deficits that we don't really understand. And a good example came from the world of dyslexia. So dyslexia is defined as a reading specific disorder. So that is to say, people who have trouble reading but who have normal or superior perhaps intelligence without having any obvious neurological problems or some sort of more generalized learning difficulties. It's a reading specific deficit. And there's a real debate about, well, what's going on in the brain, where does that come from? And everyone thought, oh, this is great. Now that we have things like fMRI, we can just put some dyslexics in a scanner, we can put some normal kids in a scanner, and we can just sort of compare what's happening in their brains. And that's exactly what this study did. It was really early days, so they analyzed it in a funny way, which is why you get this kind of image. But what it's showing is the average activation across a whole bunch of cortical territories labeled by their Brodmann's areas. So for instance, you can see that in the frontal cortex of the brain, there's areas 45, 44, and 46, which are two prefrontal regions. And you can see that in the non-impaired population, for instance, they show sort of a medium gray activation. Whereas if you look at the dyslexics, you can see that their activation is much greater there. So there's a difference in terms of those parts of the brain. But in addition, there's an underactivation in the dyslexics in area 22, 39, and 37. So the more posterior parts of the temporal parietal areas. Relative to the normal readers that show these black regions there that show greater activation, the dyslexics are showing less activation here. And this is potentially interesting, but it immediately raises the question, what does it mean, right? Because there's two possibilities. It could be that those underactivations are why the dyslexics have trouble reading, because this is a reading task. It could be that they don't activate these enough, and if they activated them more, they'd be able to read better like normal, healthy readers. On the other hand, and that I think is the interpretation that people want to see out of this, but there's nothing to separate that interpretation from the fact that these regions aren't activating because they're not as good a reader. That is to say, they're just not doing as much reading. It's more hard for them. They read fewer words in the same amount of time. So there's less activation because they're doing less reading. So that is, it's really hard to draw any sort of causal link here. In fact, you can't. Is it the case that the lower activation causes their reading deficits? Or is it the case that their reading deficits cause the lower activation? There's no way to answer that from this kind of a design. And the problem is because two things are varying, right? Their behavior varies. That's how we pick the participants, and we put them in for a reading task where one reads well and one doesn't. And their activation varies. So there's a correlation, and that's interesting. But what does it tell you? Well, it tells you that they're not the same, those two groups. Okay? I knew they weren't the same because that's how they were recruited. I picked one of the groups for being good readers and one of the groups for being not good readers. I knew they weren't the same. What did this particular fMRI study tell me? Arguably, it told you nothing at all. It showed you that they were not the same, and they're not the same in their brains either. Right? So unless I wanted to take a really strong dualist kind of Cartesian view of things and think, well, behavior doesn't really depend on brains, so that's an interesting link. As a neuroscientist, it's not a kind of perspective that I take very often. I tend to think that behavior depends intrinsically on brains, and that there is no difference in behavior that isn't reified by some difference in the brain too. We just don't necessarily know what it is. So the fact that there's a difference in the group and there's a difference in their activations is basically telling me brains, behavior are linked. I knew that. That's hard though, right? Because that is exactly what a neuropsychologist will do. They look for where patients differ from one another. They look for the things that they can do, they look for the things they can't do, and they try to characterize those impairments because that's what cognitive neuropsychology is all about. And there's absolutely nothing wrong with that. It's really important, and understanding the nature of those deficits and how they co-occur is a super valuable thing to do from a behavioral side of things. But if you're interested in their brain basis, what you actually need to do is find out where you can scan patients on tasks they can perform, right? So that is to say, if you make sure that their behavior is matched between the patients and the controls, and you still see differences in the activation, that's when something interesting can be said about them. And let's talk about an example there. Right, so for instance, this the activation on the left here is for a semantic task where you sort of got people looking at words and deciding whether they're man-made or not, right? So there's a very large frontal activation in our normal subjects, and they have no trouble doing this task. Interestingly, if you have patients with sort of a classic Broca's area lesion, so that they have a lot of damage to exactly that part of the prefrontal cortex, they can still do this task, right? Despite the fact that, as you can see on the right, this is a given patient who is missing a large part of that prefrontal cortex that would be active in normal subjects, and yet he does the task as accurately as normals and as quickly as normals. In other words, his behavior is exactly within the normal range. Well, what's going on there? How does that happen, right? Well, there are a couple things that we can focus on. So, for instance, these areas shown in the sort of light blue are areas of reduced activation. Obviously, there's less activation in the lesion because that bit of the brain is missing, but he still can do the task, which suggests that maybe that area isn't necessary in order to do it to begin with. But it's also worth pointing out that there's less activation ipsilaterally, that is on the same side, in the cerebellum, right? So that's not an area that's damaged. It's on the order of 10 centimeters away from the damaged tissue, and yet it's showing an abnormal response, which again suggests that that part of the brain may not be necessary for performing this task. There's also an area that's showing increased activation, right? So that is to say, on this temporoparietal junction, there's activation in the patient that's not there in the normals. Well, what's going on with that? What's happening in this sort of overactivation? Is it the case that this is something that mediates recovery? Like, is the reason that this participant can do this task because they're not using the full normal pre-morbid system? They've found a different way to do it that involves this kind of temporoparietal junction, something in the angular gyrus. And if that's the case, how did that come about? Is it because as soon as the stroke hit, there was this latent system and they just sort of took advantage of the fact that it was there and they just didn't need to use it before? Or have they changed their cognitive strategy? Are they doing this task in a different way than the normal subjects are doing the task, and therefore they're using different cortical anatomy to do it? Another possibility is that maybe the behavior is the same, but it's just simply harder for the patient, and we're not picking a sensitive enough measure to measure this kind of difficulty. But when we look at their activation, we see an increase in activity simply due to the fact that it's harder. So it's sort of an incidental activation. And all of these are possibilities, but these are much, much more interesting possibilities that we can start to tease apart than the ability to say these two groups of patients, patients versus normals, are not the same, right? Like, we knew they weren't the same to begin with. That's why this is a patient, that's why this is a normal subject. So just saying that their brains aren't the same either, not very meaningful. If you scan them on a task they can perform so that the behavior is matched but the activations differ, then you start to get at the interesting questions. Are these regions actually necessary for performing this task? If they aren't necessary, why is that? Is that because there are latent systems that become uninhibited when the lesion strikes and you can just use them? Or are they things that people have learned in order to compensate over time? And for instance, with something like that, you might think, well, great. That's the kind of thing we can tease apart because we can test these patients at different points in their recovery. So for instance, if it's a latent system, then pretty soon after the stroke, it should be available for them to use, and we should see that 2-3 weeks later, whereas if it's something that they had to relearn, it may not be available for like another year or 2 years afterwards. And if we scan them longitudinally, we can start to address those kind of questions. So, if you're interested in scanning patients, and they may be neurological patients like the one that I just showed you, or there may be some sort of functional deficit like dyslexia where there's no obvious neurological link, then you are faced with a whole range of questions. And there's a really good literature out there. I'd say a significant portion of it was written by Kathy Price and Carl Friston. If you're interested, I highly recommend the paper that's included at the end today that this comes from. But what you need to determine first is, if you've matched their behavior, do you see an abnormal pattern of activation? If you don't, then maybe the lesion just simply affected an area that wasn't involved in the task, and that's not particularly interesting. But if you do see an abnormal pattern of activation, how do we interpret it? Is it due to compensatory changes in the architecture, that is, these latent systems becoming uncovered? Or is it due to sort of compensatory changes in the cognitive architecture? You're like doing the task in a different way, whether that's something you've learned or whether you've just decided you can answer this multiple ways, and now you're going to focus on route 1 instead of route 2 because route 2 is damaged. And if so, is it something that was there from the beginning, or did you have to learn it, right? So you can work through this tree. If it was something immediate, is it a local effect of the lesion? Is it just that the tissue there is damaged and therefore is not so active? Or is it a distant effect of the lesion? And we saw that in the cerebellum in that stroke patient, where there was a lack of activation ipsilaterally in the cerebellum, despite the fact that that tissue was completely unaffected in terms of structural damage by the stroke. And that tells you something about what's known as diaschisis effects. This would be a dynamic diaschisis, that is a lesion effect distant from the actual lesion itself, that's coming about functionally, if not structurally, versus uncovering systems that are in place to begin with, but perhaps aren't being used to their full capacity because you have a system that's perfectly good, and then when you damage that, you rely on these kind of alternatives that exist sort of underneath, as it were, the actual functional system. There's a ton of issues with scanning patients, and if they're neurological patients, you get additional methodological and physiological issues. So for instance, stroke patients, for instance, have abnormal blood flow, which means that you're going to get changes to your bulb response, and it may be the case that your assumptions of the hemodynamic response are not equally valid between normal subjects and your patients, and that's another thing that you need to take into account. So if you're thinking that this is the area that you're really interested in, then there's a ton of complexity here. All I've done is really scratch the surface and hopefully pointed you towards that literature. We really won't have time to cover it in full, but we could run an entire module, like a whole term, on just the scanning patients and the complexities involved, because there's a ton of really, really interesting stuff. One of the things I mentioned is this possibility of doing longitudinal fMR, and this is something that comes up in multiple circumstances, most often with patients, but I wanted to just raise it because it relates to this idea of intrinsic variability in the Bolt signal, right? So I've already suggested, when we talked about functional localizers, that if you're on the same task in the same person, 2 minutes apart, you don't always get the same exact activations. Well, this is a real issue if you're doing longitudinal fMR, because the whole idea is you're going to scan people at different points in time and compare them, right? And the assumption is that the only thing that varies from time A to time B to time C is whatever interventions happened. It might be because people are recovering from a stroke. It might be because between time A and time B you've done TMS with them, or you've given them a drug or something. There's been an intervention over time, or maybe they've just simply learned a new task, or to do a task a new way. But for that assumption to be true, then you need to control the fact that just simply scanning them for 2 different sessions has a certain amount of variability. You want to get rid of that variability, right? So this is a study that Jamila Ando did a little while back, where she scanned she scanned normal healthy subjects before and after TMS, right? So again, this is that brain stimulation through transcranial magnetic stimulation. And you can see that the area highlighted here is Wernicke's area. This was a speech task. And you can see that in the speech task before TMS, which is shown on the left, there's a fair amount of activity in, say, posterior superior temporal sulcus, all along the temporal lobes into Broca's area, etc. In contrast, after she stimulated that part of the brain with a sequence of TMS that's designed to suppress activity in the brain, you can see there's quite a bit less activity in Wernicke's area, that's posterior STS area, shown here on the right, and even less activation in the anterior parts of the temporal lobe and Broca's area. So one possible interpretation here is that TMS did exactly what she expected, That is, by suppressing the activation in Wernicke's area, it reduced the activation in areas linked to Wernicke's area along the temporal lobe and into Broca's area. But an equally valid interpretation of this would be to say, well, she scanned the same people doing the same task twice at 2 different times. Maybe it's just normal variation. How do we know that's not the case? And if your design is such that all you're interested in is task versus rest, or task, one task compared to another at point A and then point B, there's no way to tell that apart. What you actually need to do is build in something that won't change over time as well. So you need to look for an interaction in your design, so that you're looking at task versus rest that you're expected to change because of your intervention, and another task versus rest that you're not expecting to change due to your intervention. And you want to look at how they are different between each other in time A, before your intervention, and time B, after your intervention. You're looking for an interaction with time, because you're hoping that the task that doesn't change, right? If it does change, then any way that it changed from A to B, you need to discount as a possible effect of your intervention, because it's potentially simply due to the fact that you scanned them twice. Let me try to make this a little bit clearer. A little while back, Dave McGonigal at the Phil here at UCL did this kind of heroic study where every day at 8 o'clock in the morning, he would come in and scan himself doing a block design finger tapping task. That is to say, he would do this for 30 seconds and then stop for 30 seconds, and then do this for 30 seconds and then stop. And he did this for 2 reasons. One, because as a block design and using a motor task compared to a rest condition, you just get the most robust effects, right? He's taking advantage of a low-level baseline, he's looking for a big physiological difference, and he knew exactly where they should be. They should be in motor areas of the motor cortex, right? But what was heroic about this is that he did it every day at the same time for 33 days in a row, weekends and all. He'd just come in every morning, spend an hour scanning himself, doing the same boring task every day for the same amount of time. These are the activations for him doing the same task, comparing motor versus rest, each of those 33 days, right? So in a lot of them, you can see that, this is what's called a glass brain representation. And it's a little bit hard to get a feel for, but for the most part, let's just assume that the activations in the more superior parts of the brain are primary motor cortex. There's often activation in the cerebellum as well. And what you can see, right, is that some days, really, really robust motor cortex activation. Day 1, day 3, day 12, day 15. Other days, there's much less activation in the motor cortex. Look at day 33, or day 13, or day 7. Day 7 doesn't show any activation in primary motor cortex. I mean, what's going on? He was doing the same task, the same way, same hand, same brain, every time. What's happening here? Well, this is an example of just how variable each fMR session can be, right? This is an illustration of the variability in an individual over time performing the same task in the same way. So there's a fair amount of commonality, and that's really encouraging, because if it wasn't there, then you'd think maybe fMR is total nonsense and we shouldn't be doing it at all. But there's also a fair amount of variability, such that if you were to say compare day 1 with day 7 and say, okay, well, clearly what's happened is something's changed from day 1 to day 7, like somebody TMS'd his motor cortex and suppressed activation there. Well, no, that's not what happened. I mean, it's the same guy doing the same stuff. That's just normal day-to-day variability. And with that in mind, it makes it difficult to look back at the Ando study and say, oh, well, I could say with confidence that that was a TMS effect, as opposed to just simply due to the fact that the data have been collected on different days, and it could just simply be a scan-to-scan variability issue. Okay, last topic before I stop for this week, and I want to talk about behavior versus bold. I guess the question that I want to ask is, do you always need a behavioral measure when you're scanning? And I think that the answer is, it depends, right? So in certain circumstances, the answer is clearly no. Like, what if the behavioral task changes the thing that you're interested in measuring? Or what if you're actually trying to measure things in people who can't respond? It could be patients who couldn't respond, or the Van Duffel experiment where, you can't really ask the monkey, did you see the 3D shape? But we know for a fact that through behavioral experiments that monkeys do extract 3D information from motion in the same way that people do. The question was, how did that play out in the brain? And in that case, you clearly don't need a behavioral measure because we have evidence to believe that it's happening in the same way. In other experiments, it's different, right? And the answer is going to be very clear. Yes, you absolutely need behavior if it matters what your participants are doing. So let's consider the reading experiment with the dyslexics and the non-dyslexics, right? If they're performing at the same level, then that's really important because then you can interpret those data. You can see that the patients are performing a task, as well as normals. And the only way you can show that is through having data that shows that behavior is matched. In contrast, if they're performing in a different way, then both behavior and activation are changing and you can't interpret the data other than to say, yep, not the same. And in other cases, what you're really interested in is a behavior. If you're doing a learning study or you're doing a priming study or something like that, then if there's no evidence that the participants learned or there's no evidence that primings happened, which are both behavioral questions, then how do you interpret the activations? Because it could just be noise due to the fact that there's variability, right? You need behavior to illustrate the fact that your behavioral question is being handled properly. So let's unpack that a little bit. So one of the things I said is that a task could interfere with what you're interested in measuring. So this is a study that went on quite a few years ago out of Richard Wise's group, and they looked at what happens when people are listening to stories. So if you just passively listen to a story and just try to understand it, and then come out of the scanner and, for instance, do a memory test afterwards, then while you're in the scanner, there was no behavioral paradigm that was going on. You're just listening. Versus if you're in the scanner and listening to a story and say every once in a while I embed a beep in it and just simply ask you to push a button every time you hear the beep. And that just lets me know that you're paying attention, like you haven't fallen asleep in the scanner. Then I've put a behavioral task, but what I'm really interested in is the story that's happening. I don't think that the beep stuff is particularly interesting. I can always take out, primary motor cortex or for instance. But you can see here that when you do it as a passive task, which is shown on the top, versus you do it with an active task, there's some commonality, but there are some big areas of activation that differ as well, and prefrontal cortex is a big area there. And to be honest, because most people tended to default to behavioral tasks when they were doing these studies early on in the 90s and early 2000s, people were starting to say, well, prefrontal cortex obviously plays an important part in understanding stories. And of course you could understand that, you could make a story about it. But it was surprising because it's not what we see from patients with prefrontal lesions typically. There's some exceptions to that, but in general. But this is a case where adding a task changes the activations, and it changed our interpretations of the activations. There was a big question about the role of prefrontal cortex in understanding sentences and understanding stories. Well, is that because of the story or is that because of the task, right? Of course, there's another possibility here, which is that what if you're actually testing patients who can't respond? And this is some really interesting work that Adrian Owen's group did, where he was looking at patients in a persistent vegetative state. So these are patients who, in the morning, they wake up, their eyes open, but they just show no behavioral response to the stimuli around them. So for instance, even if you ask them, look, if you can hear me, can you please blink your eyes? Their eyes will blink sometimes and not other times, and there's just no evidence that they can respond to anything in their environment. So it raises this really important question, which is, are they there, right? I mean, is it the case that there's a person who's essentially trapped in their body and has no volitional control in order to respond? Or is it more like the lights are on, but nobody's home, right? Where what's unique about that person is simply gone. And this is more than an academic question for family and for carers. This is absolutely the central question because they spend a lot of time thinking, is my loved one there or are they not there? And how do we best care for them? Because they're often on these life support systems. And there are legal cases like Terry Schiavo in Florida several years ago where the family said, look, Terry's gone. I want you to shut down the life support because you're just prolonging everybody's agony. And the doctors said, look, we understand where you're coming from, but the Hippocratic Oath suggests that we can't shut down life support. And sometimes it plays out the other way. Sometimes doctors will say, look, far as we can tell, this person's gone, and the family will swear that occasionally they get responses that they're convinced their loved one's there, and the last thing they want is to shut down their life support. And these become really horrible cases in the news and in the courts. Wouldn't it be great if you could use something like fMRI to answer the question definitively? And that's actually what Adrian Owen managed to do. So by definition, the subjects can't behave. So he had to come up with a task that he could look at brain activation in a meaningful way in an individual to see whether or not the participant was alive and conscious versus maybe not. And what he did was quite clever. He came up with an imagination task, right? So you can ask people, imagine yourself playing tennis. Everybody knows the game, whether or not you can play it or not, but he's just say, like, imagine, serving the ball to your opponent and then watching them hit it back to you, and then you running over to where it is and hitting it back to them, etc. So you can imagine playing tennis. And of course, it doesn't involve any overt behavior, but it does involve a volitional behavior. I mean, imagining is a kind of thing that you can control in your own head. And he would contrast that with imagining walking from your kitchen in your house to your bedroom. Okay, so again, it's an area that you're familiar with. You understand the spatial layout. You can presumably have walked between your bedroom and your kitchen hundreds and hundreds of thousands of times. So it's an easy thing to do. And the thing is, if you do it in normal healthy subjects, which is what's shown here on the bottom of this slide, there's a big difference in the activation. So when you imagine playing tennis, you get this very robust activation along the midline in an area called the supplemental motor area, or the SMA. In contrast, when you ask people to imagine walking from their bedroom to their kitchen or vice versa, then you get this kind of set of regions that's a real spatial navigation system from what's called the parahippocampal place area through the posterior parietal cortex into parts of the lateral premotor cortex. So this is not the medial. So although those two activations in the front look quite similar, one is slightly on the side and one is along the midline. And they're very distinct. And what's fascinating is the very first patient that Adrian did this with is shown above. That is her activation when asked to imagine playing tennis and asked to imagine walking from her bedroom to her kitchen. I think that we can all agree that that activation is very clear, right? The chances of getting that by chance are essentially nil. She's showing the pattern that exactly matches normal subjects who are healthy and can behave. And by chance, although she had been in this persistent vegetative state for several years at the time that this study was done, she awoke, I guess is the right word, from it within 6 months of this. And it was just about the time that Adrian was publishing the work. And the media got a hold of it and said that Adrian had cured her. That really made Adrian very, very uncomfortable. That's not the case at all. I mean, she whatever recovered from the state. But when she recovered, you could also ask her questions like, could you hear us? What was it like for you? And she said, I could hear you the whole time. It was so frustrating. I couldn't respond. But every time you were there, it made a difference to me. And you can imagine that both carers and family members, the world around who have loved ones in this state, took this to heart and said, okay, well, I'm going to redouble our efforts to make sure because maybe our loved one will recover. And that's the kind of question that you couldn't have answered without using fMR. But of course, there was no behavior in this. And it turns out, so there's been a lot of work on this since then. And Adrian has a great book called Into the Gray Zone where he talks about some of this work if you're interested. About 20% of the patients that Adrian's tested over the years show this pattern. The other 80% don't. And of course, that also raises interesting ethical questions like, would you use that lack of a response to say they're not there and therefore it's okay to turn off the life support system? Adrian's super clear with that. He's like, absolutely not. I would not. There are all sorts of reasons why you could have a null result. But a positive result tells you something useful. A negative result in this case doesn't provide any extra information. Okay, so what about the flip side of this, right? And that is that some questions that we ask are fundamentally questions about behavior, learning tasks, priming tasks, and even TMS tasks. For the most part, when you do TMS, you're assuming that TMS to the region of interest is going to change someone's behavior. If it doesn't, you have no reason to believe that you stimulated the right spot in the right time or whatever. You may have just simply done the TMS wrong. So you need a behavioral change in order to demonstrate that your physiological intervention, in this case the brain stimulation, has had an effect. And without that, any changes that you see in the brain activity are potentially meaningless. They could simply be due to any number of other random noise factors. So it's really important that if you're asking a behavioral question, that you collect behavior in order to look at those effects. And let me just give a couple of examples of this. Kevin Murphy and I think it's Ian Garavan, did this cool study where they had people doing, I think it was a working memory task, and they had, they just sort of analyzed all of the data, right and wrong. And it was a hard task, so sometimes subjects got questions wrong. And you get a certain pattern of activation. But if you simply divide it up afterwards and say, well, what about if you only analyze the questions that they got right and take out the things that they got wrong, well, then you get a very different pattern. So that's what's shown there in red on the left, where you're only looking at the no errors. There's a very specific pattern of activation in a part of the pars triangularis in the prefrontal cortex that is there in the times when subjects got 1 error or 2 errors or however many errors, but there's a lot of other things going on too. And in fact, subjects make enough errors that if you just include errors and non-errors, you get a much larger activation that includes other areas of the brain that you think is related to the task, but in fact, in this case, is linked to a specific behavior that wasn't of interest, which is getting the problem wrong. Okay, so one of the things that is often a good thing to be able to do is include in your design temporal jitter, even if it's a block design, so that you can post hoc separate out correct and incorrect answers and only analyze the correct ones so that it's not contaminated by, for instance, the errors, where there could be very different sets of cognitive processes going on. In addition, there are behavioral compounds to take into account. So this is a study that Tai Toomey did several years ago. And she was looking at the way people respond to different types of words. And you can see here that there were 4 categories of words in these 4 lines. And this is their behavior in terms of reaction times. The one on the white, the one on the white, right. The one on the left in white is the one that people found easiest and they responded fastest, around 750 milliseconds. Then it went progressively up till you get to the one on the right in black, where people are responding at just over 1100 milliseconds. So clearly there's a behavioral difference in these 4 different types of stimuli. But there were 3 areas of the brain that showed activation, and you can see them there on the right in that brain image. The angular gyrus, which is that posterior parietal region, showed this pattern of activation. So it exactly mirrored the reaction times, but in reverse. So the greatest activation was for the fastest, and then there was a little bit less activation, more deactivation, for the 2 in between, and then the one that showed the longest reaction time showed the greatest deactivation. Well, what's going on is, one possibility is by knowing that behavior and seeing that behavior played out, in this case in opposite, in this part of the brain, this could just be an effort effect. Like literally, if you spent more time doing the task, you see greater deactivation in this part of your brain. And in fact, this is a key region in what's sometimes known as the default mode network, which this is a characteristic pattern for. So it's not the case that this part of the brain cares about this particular task and these stimuli. It seems to be effort-based. But without knowing the behavior, there'd be no way to make that interpretation. And in fact, you'd probably interpret it very wrongly. In contrast, a different part of the brain, this sort of visual word form area, or ventral occipital temporal region that I've mentioned several times, showed a more complicated pattern, right, that didn't match the behavior. And what's important here is by not matching the behavior, you can say that this is a part of the brain that's responding in a way that isn't about effort, right? I mean, it very clearly, if it was just effort, that black bar would be the highest in that set, but it's not. It's clearly there's something else going on in this region, and then you can interpret this in terms of the information processing characteristics of the task or the stimuli without, for instance, thinking about the overall amount of effort in terms of reaction times. But without knowing the behavior, your interpretation of your results would be very different. Okay, so you have once again made it through a heroic set of 3 lectures. A lot of information there, but hopefully it's all going in. There's an opportunity to ask any questions, of course, as always on the Moodle page. There's a hot questions part of Moodle. So anything that's not clear, do please put in those questions and vote up questions that are of interest to you or that you'd like to know too. Make sure to try to answer those, and hopefully, if anybody also wants to answer them, do please go ahead. But some of the take-home messages from today's or this week's lectures are that sparse sampling was designed for auditory imaging, but can be used in other areas like TMS, and it presents a number of design considerations that you need to take into account. The fact that there's statistical sensitivity issues is first and foremost among them, and also the fact that you get these sampling bias issues due to the fact that the default potential here is to make sure that the interstimulus interval, that is the stimulation, and the TR, the recording of the data, are locked in time. You want to avoid that if you care about an area outside of, say, auditory cortex, where it's just one region. Functional localizers are one of the most common additional things used beyond event-related or block design, but they represent a reasonably sophisticated little ploy that has important implications, whether you do it as independent scans or whether you build it in sort of a design where the contrasts of interest or orthogonal to another is important. If you do the latter, then you don't have to worry about reproducibility because it's the same data. But if it's the former, that is, it's an independent set of scans, then you really do need to think about how much data to collect, how to analyze those data, and how confident you are that you've identified the right patch from your functional localizer to your main scan. Conjunction designs are another thing that are surprisingly common, although people often don't acknowledge it, that it's a conjunction design, but that's the logic that they're using. They're looking for overlap between two orthogonal, that is independent contrasts, or more than two. But the key here is they do have to be orthogonal. If they're not independent, then any overlap you see can be a spurious result of this non-independence. If it's not there, it's not a proper conjunction design. If you're interested in scanning patients, be they functional patients like dyslexics or somebody with mental health issues like depression or OCD or whatever the case may be, or neurological patients, stroke patients, Alzheimer's patients, whatever it is, then you're in a really fascinating area, but you need to bear in mind that there are a rich set of design issues that you need to think about. The most basic is that you absolutely need to make sure that you're testing them on a task that they can perform within the normal level. If you're going to be comparing them to normals, then you need to make sure that their behavior is matched so that you can interpret the results. Those interpretations are going to be complicated, and there are great review articles like that Price and Friston paper that I highly recommend, but it's a fun topic because of some of the complexities there. And then finally, the relationship between behavior and bold is really complicated. There are some times when it really matters that you get behavior and you look at your bold data, because there's no way to interpret one in the absence of the other. There's no way to interpret the bold without actually having access to the behavior. In other cases, it may not be possible to collect the behavior, or collecting some sort of behavior may change the pattern of brain activation that you're actually really interested in. In those cases, it's important to make sure that you don't collect the behavior at the same time. It is possible on those scenarios to possibly collect the data, afterwards. So for instance, in listening to stories, you can get people out of the scanner afterwards and then give them a memory quiz and say anybody who just scores below like chance or something, then you just throw out their data because you have no evidence that they were doing the task. But because this test happens once they're out of the scanner, it's a more ecologically valid way of trying to understand what they were doing when they were in the scanner. And things like that may be an option in some cases. And as always, at the end of the week, I'd like to provide a suggested reading list. There's no extra book chapter to read this week. So what I would really love to encourage you to do is to make sure that you are reading some of these papers. It could be the papers from today about any topic of interest. It could be something from the last 2 weeks. But I'd like to encourage you this week to make sure that you read at least 2 articles from the first 3 weeks in the extras. Doesn't matter what they are. I would encourage you to read things that sound really interesting to you. And sometimes they're hard and challenging and all the rest of it. That's okay. Read it anyway. Work through it. If you have any questions or you want to bring it up, then that's what those discussion forum is, or those hot topic questions in Moodle are good for. Plus, obviously, we have a chance to talk about it during the weekly session on Thursday. Thank you very much.